Right. Okay. So my name's Ammar. I'm one of the dentists that's doing root canal treatment in the London area at the moment. I'd like to thank Hannah and the Kiroku team for allowing me to present a little bit on pre-endodontic assessments, going through clinical steps as to how we would go through an endodontic pre-assessment from start to finish, so we don't really miss anything out. So everything from the clinical aspect, radiographically, and things just spot. I think this is quite important because if we get this right, we'll know if we can improve on a root canal treatment that was previously done, and we can diagnose a root canal treatment that needs to be done and how to go about doing it, and whether or not it's within our competency, or we may need to refer it on to somebody else who may have had a little bit more experience or training to be able to do that for you. So I think it's a really good way just to assess the steps, refresh our memories, look at special investigations that we might do, and just really update ourselves with what's out there at the moment with regards to pre-assessment. It's not something that we discuss that often. It's not a particularly sexy topic, but I think it's one of the fundamental pillars to get it right every single time. At the very end, as Hannah said, we'll go through the Kiroku setup and how that can help you in the dental environment. Cutting down your note-taking and hopefully making things a little bit more swift and smoother, especially in the coronavirus pandemic that we've got at the moment. So you don't really want to be in your clinical surgery for too long. So we'll go through that as well. So I'm just going to get started. So a little bit about myself. I graduated in Glasgow Dental School in 2009. I did my VT in the Scottish Highlands. I then worked as an SHO for a few years at Dundee Dental Hospital, Glasgow Dental Hospital, Preston, and Ninewells in Dundee. I worked in practice for a few years, and I worked in the emergency dental services, and that's when I realized I wanted to do endodontics. I was basically doing more and more endodontics in practice, and I think I just fell into it more than anything else. I finished my endodontic training at Liverpool, and I'm now working in a practice limited only to endodontics in London. And I do some lecturing at the University of Liverpool to the postgraduate students. So you can ask me any of these, what my experiences are at the end if you wish. It's not a problem at all. Learning outcomes, we are looking at case assessment tools, and these are quite important because it just allows you to look at a case and know whether or not you're comfortable doing it, or whether you want to refer it to someone else to have a look at it for you and attempt the root canal treatment. We'll look at the pre-assessment of the teeth requiring root canal treatment, and that's primary and re-RCT. We'll do a diagnosis recap. We'll look at special investigations, and why we use them and why are they so important. And then we'll look at a little bit on outcomes at the very end. We're trying to keep this talk as short as possible, maybe 35, 40 minutes, so that we can do the demo of the Kiroku at the very end. So case assessments are key to success in root canal treatment. Always try to assess the complexity of the treatment before you go ahead with root canal therapy, so that you can discuss with the patient the best ways to get the best outcome. And things that you need to be looking at is elements that we're going to be discussing at the next slide. But the case assessment tool is a way for you to basically look at a case and know whether or not it's something that you're comfortable to attempt. If you're comfortable with it, be confident with it, go ahead and do it to the best of your ability. But if you're in doubt, that's the time to refer. So it's a really good medical legal way to prevent you getting into any complications with patients and knowing your limitations with regards to the complexity of root canal treatment. So how do we look at the complexity? Well, we're looking at a number of things. We're looking at the patient factors, so the medications, whether they have bleeding disorders, they're taking bisphosphonates, they've had radio and chemotherapy, are they past cancer patient, are they on immunosuppressants? And these are all things which might make you think, well, let's try to save this tooth, because removing it might cause us more complications, especially with regards to patients on IV bisphosphonates or those who've had radiotherapy in the jaw. Other factors is trismus and mouth opening. So if patients got limited mouth opening, less than 35 millimeters incisively, then it makes it a little bit more difficult to do the root canal treatment. So you need to be assessing whether you can get good access, are you having limited access, or do you have poor access, and whether or not you might then need to refer to a specialist or to get sedation at the same time, especially for gag patients, to allow you to do the root canal treatment more successfully. Physical limitations such as, can they lie down flat, do they need to lie at an angle, for a period of time? Can they even sit for a period of time flat? And that might all make it very difficult for you to actually access the tooth itself and make accessibility quite difficult. Can they tolerate a periapical radiograph? If they can't, then it might be very difficult to put rubber dam on and actually carry out root canal treatment to the best of your ability. Dental history, things that we're looking at is trauma, previous trauma. What effect has that had on the tooth? Has it had resorption? Does it have an open apex? Has it had any sclerosis? Can you see the root canal system? So these are little things that you're trying to look for from previous trauma and the complications of trauma. Previous root canal treatment. So how was it done? Was it done under rubber dam? How well was it cleaned? Did they get to the working length? Is there any mishaps that have been carried out throughout the root canal treatment, such as a perforation or a ledge? Has there been a separated instrument in the root canal system? These are all little things that can make root canal treatment more difficult, attempting the root canal treatment more difficult. You might need specific tools to be able to do the root canal treatment to the best of your ability. And therefore you might think, well, you know what, I might just refer this on and get someone else to have a look at it for me who may have a better success rate. And that's absolutely fine. Other things we're looking at is restorability. So can we get isolation in the tooth? So we're looking at the tooth as a whole substance. Do we have enough tooth substance or not? And there's a lot of studies coming out now showing us that a reduction of tooth material, such as less than 30% of the tooth structure left, we may be having a lower prognosis long-term and may increase the likelihood of extraction. So looking at how much tooth we've got left and can we put a predictable cuspal coverage restoration will really, really help. So this is something you need to look at. Can I restore this tooth? Can it be restored well? Can we get long-term outcome from this? Can it be functional for a long period of time? We're looking at if the tooth's been crowned. So are we going to go through the crown or are we going to remove the crown? And that's quite an important question. If it's a new crown, the patient might not feel comfortable that you're going to be removing it. But then going through a crown means that you don't really know how much of the core you've got left. We don't know if there's decay underneath that crown. You don't know why that crown's failed. Is there an open margin somewhere? And it's much more difficult, therefore, to actually sometimes locate the canals. It's much darker to treat a tooth through the crown. And you might actually physically cause more destruction to the core, causing the whole tooth to physically fracture. And then looking at the restoration. Do we have a large filling? Do we need to remove all that filling? Do we need to keep some of it on? Do we need to rebuild the tooth? Is the tooth physically restorable? And that's again going back to the isolation element, in the sense that if you can't get a rubber dam on, then we really shouldn't be doing root canal treatment, because the risks of potentially the patient swallowing a file or swallowing some of the irrigant solutions that we're using may cause harm. So that's an important element. Another element that we're looking at is the tooth itself. You know, the angulation of the tooth within the arch. Is it rotated? Is it tilted? And that will mean that trying to do our access cavity will be a little bit different. We need to look at it with a fresh pair of eyes. We might need to do it in a way that, you know, we prevent getting potential perforations. Curvature is a big problem. So is the roots at less than 30 degrees curvature, which makes it relatively favorable to do in general practice, or is it less than 45 degrees, which is a bit more curve, and therefore we need to have special considerations in how we're going to tackle this root, or is it greater than 45 degrees? And the risks here is that you might potentially ledge, you might potentially separate the instrument. With NITI instruments being so flexible, they're great, but they also have their limitations. They don't like going around the curve for too long because they essentially undergo cyclical fatigue, whereby the file is overworked and then it snaps. So that's something you need to consider, and you might need to consider the file that you might use. Not all files will be able to go around the curve very well. Again, sclerosis is another one. When you can't see the canal radiographically, then it's sometimes difficult to locate it, especially when you don't have magnification. Sometimes you might need a CBCT before you start to see what's going on with that tooth and whether a physical canal is present. Do you go surgically straight away, or do you go through the tooth as normal? So that's little questions that you then need to ask yourself. A great tool to use is the American Association of Endodontology AAE complexity tool. It breaks down a tooth into 3 categories: minimal difficulty, which is basically a root canal treatment that should be attempted or can be attempted with minimal difficulty in general practice; moderate difficulty, where they might have more than one of those complications that we discussed earlier in the case assessment tool; or high complexity, it has multiple challenges to it, and maybe it needs to be referred to a specialist to have a look at. And therefore, this tool is great. You can download it online. I've got it laminated in the practice when I was at GDP, and it's a great little tool to use. The University of Liverpool are forming a newer tool, which is a tool based on using your phone, based on certain algorithms, called the ECAT, and hopefully in the not too distant future, it will be released to the masses. So preoperatively, we're looking at a number of things. We're looking at the chief complaints and desires of the patient, which we're not going to really touch on that much, but we're going to really be touching on the periodontal prognosis, so looking at the periodontal attachment of this tooth, the restorability, how much tooth have we got left, is it physically possible to fix this tooth, or should we look at another option, and endodontic prognosis, looking at previous root canal treatment or the anatomy of the tooth and whether or not there's something we should treat. And the combination of all these things together means that we can then have an overall treatment plan. We can then confidently say to the patient, what is our long-term prognosis of this tooth? Is it good? Is it guarded, or is it poor? And we know from the outset, by looking at these things, these factors, they can give us a good outline as to where we go next. So restorability-wise, look at the caries extent. So you need to remove all the caries, obviously, first and foremost, and see how much tooth you've got left. Look at the remaining tooth substance that you've got left. Look at the position of the margins. Are they supra or subgingival? Look at the occlusion. Is this tooth part of guidance? Is the patient canine guided, where posteriorly then it's not much of a problem? Trauma. Has this tooth had trauma in the past? Is there a crack or a fracture in there that maybe has been missed previously, or has had resorption, an open apex, or something else that's undergone a complication that's taken place as a sequelae of the trauma? And the interocclusal clearance, do we have enough space left to physically put a crown on this tooth when you're done? Has there been over eruption? You need to think about other options as well to create space. And again, cracks. So a good tip that we got taught during specialist training is that if you're really unsure, do a crown prep before you do the root canal treatment, and that will show you exactly where your margins are and allows you to assess the margins, and then you can tell whether or not this tooth is a goer, or we should hold fire and think about other options, or sometimes you might need to think about crown lengthening. So that's when you might need to bring in another specialty to have a look at that tooth and to give you another, to eyeball the tooth and see whether some of the bone structure might need to be removed to create a little bit more of a ferrule. And it's things like this that come through into your practice. What do you do with these teeth? Do you restore them? Do you take them out? And there's different varieties of how you're looking at it. Patients' oral hygiene, their compliance, how much the patient wants to save the tooth. But also, how old is the patient? You might need to think about, well, we could potentially put an implant in this case, which might give the patient a longer term outcome and survival than the root canal treatment, which may potentially fracture because you might need to then do crown lengthening and other things to this tooth. So the more aspects and layers within the treatment that is required, sometimes the more complexity it may have, and therefore the prognosis may drop. So these are all little things that you need to consider in the back of your mind. Prognostically, you need to look at a number of factors. So how much tooth substance do we have left? The anatomical position of the tooth. So, and what I mean by that is the occlusal forces that the tooth is going to be undertaking, the amount of load that it's going to take. Is it part of guidance? Is the patient canine guided or group guided? If it's group guided, is the tooth part of guidance? And then you're looking at non-work inside interferences, which may cause long-term fractures within that tooth itself that you might want to do root canal treatment on. So examining the guidance is so important as part of the overall treatment planning, especially when it's a posterior tooth that needs to be restored with a prosthesis, a fixed prosthesis in the end. And the aesthetics, is this tooth an aesthetic part of this method, the smile, within the smile zone? And this sort of takes a really, it makes a big decision as to whether or not you want to save that tooth, or is there any other options that are much more favorable in the long run. Periodontally, we're looking at the depth of pockets. We're looking at bleeding on probing. So do we have active periodontal disease? Do we have good oral hygiene or not? Is the patient looking after their mouth? Mobility. So mobility might be caused by a number of things. Trauma, orthodontic treatment. It might be that the patient is a parafunctionist. So these are little things we need to look at, or the periodontal attachment is not great. Frication involvement in posterior teeth and suppuration. You might want to look at recession and the crown root ratio of the tooth. Is there enough tooth left to physically put a crown? And if you put that crown, is it going to put more stresses on the root? And again, you're looking at periodontal endodontic lesions. So do we have localized pockets that are caused as a result of an abscess, or is it caused as a result of periodontal disease? And that really does make a big difference as to the prognosis of that tooth long term. So the first thing we look at always is when the patient comes in, we're always tapping the tooth to feel whether or not the tooth is tender. Now, from an endodontic perspective, TTP does not mean that the tooth is vital or non-vital. All it really tells us is there's inflammation of the periodontal ligament. And this, we always need to exclude other causes as to why we've got TTP. So do we have bruxism? Is there a crack within the tooth? Periodontal disease, is there a foreign body stuck in the tooth, such as food trappings and whatnot? Trauma, previous trauma, and orthodontic treatment. These are all things that can potentially cause tenderness or percussion. So we need to always exclude one of those, exclude these things before we say whether or not the TTP is part of the inflammation caused because of periapical infection or erysipelas, and whether or not it's actually associated with other causes. So we have to exclude this first and foremost before we make that diagnosis that the nerve is dead. So TTP on its own does not tell us that information. From a pocketing point of view, we know that the normal pocket depth is anywhere between 1 and 3 millimeters, sometimes a little bit more, and that varies from different sites within the same tooth and within the mouth. And deep pocketing may indicate a number of things. So it may indicate that there's a vertical root fracture. So always try to probe around the tooth to feel for a deep pocket, especially if the tooth is heavily filled, if it's got previous root canal treatment, if it's part of bruxism, if it's heavily occluded upon. We need to make sure is there actually, if that tooth is physically viable and that doesn't have an underlying crack within it. Does it have a periendo lesion? So does the patient have periodontal disease? And usually you would know that that it's a periendo lesion because the tooth is usually vital. The patient will usually have some sort of chronic periodontitis with quite severe bone loss, vertical bone loss in some areas. If the tooth has got a periendo lesion and the tooth is non-vital, then the prognosis of that tooth is usually quite poor because you've had bone loss all the way to the apex of the tooth usually, and therefore you can't have a good apical seal once you've done the root canal treatment. An endoperio lesion is a sinus essentially, so the patient has no periodontal disease, but they've got a sinus which usually is quite close to the cervical margin rather than where it's supposed to be at the buccal wall, and it may be associated with potentially lateral canals, but it may be associated also that there's a crack. So a crack within the tooth and an endoperio lesion are very, very similar in their diagnosis, their clinical picture. So always probe 6 points around the tooth with a BPE probe, and that would be 3 points buccally or labially and 3 points palatally or lingually. Check the furcation. So with posterior teeth, always check the furcation. The furcation is quite a big deal, and a lot of us sort of miss that. Before I did my specialist training, I never really looked into it that much. But a furcation, most posterior teeth have got lateral furcation canals, and these are sites at which, if a tooth has got an infection, may cause release of endotoxins into the furcation area, and that may cause bone loss. But it may be an indication that previous root canal treatment has also failed. And again, your endotoxins and the bugs within that canal and within that pulp chamber has leaked, and it's probably leaking through the furcal lateral canals. It may potentially also mean that if you've got bone loss in that area, that there might be a breach of the furcation, such as a perforation. It may also mean that there is a crack within that tooth. So looking at the furcation is really, really important, especially if there's a swelling associated to it. It may be indicative that there might be a crack, like I said, or a perforation within that tooth. And these are little things to look for. So clinically, look at the furcal bone. There's usually a breach of the tooth substance, which you could see on a periapical radiograph. There's a cervical abscess and sinus, which is usually not where a usual sinus would usually be, or a swelling would be. It'd be a lot more apically. And you've got localized bone loss at the furcation. And that's all indicative that there may potentially be something untowards in the furcation area, which could be a breach, such as a perforation or a crack in that tooth. So they will look very, very similar. And if we're looking at radiographically, so on the top left picture, you can see that's, top right, you can see that's a periendo lesion. You can see there's a vertical bone loss on the distal root, and it's getting quite close to the apical aspect of that root. So if you were to do root canal treatment, if the bone loss extends to the apical area, then it's very, very difficult to get a good long-term outcome because the apical seal will always be compromised by the deep pocket, the bugs, the food, the saliva that's within there. So that will not work long-term, and that's when you might want to consider something like a hemisection in this tooth. Whereas on the lower left picture, you can see that you've got a long post, quite a wide post, a tapered post, which we know can cause more cracks, and a parallel post, and you can see that you've got a really deep pocket buccally, and you would know that that's a crack almost instantly because of the deep pocket and also the clinical presentation of that tooth. But if you're still unsure, you could sometimes do surgery where you can peel that back and just have a look, and you'll usually see a crack line running down the root itself. So vertical root fractures are really important. I mean, I've seen an increase of vertical root fractures recently. I'm not sure why that is, but how we would know that there is one, you've got localized deep pocket, you usually have suppuration. Radiographically, there's bone loss, so the classical J-shaped lesion or a vertical bone defect. You'll have mobility, may or may not have it, but you may sometimes have a little bit of mobility. And usually lower sevens and upper molars are usually the most commonly associated with these teeth. And usually the patient will have some parafunction, they'll have other things that, you know, together adding it all up just makes no sense as to why that tooth is failing. Another thing that you need to look for as well is a tooth that's got a very shallow restoration, that is not big, it's not breaching the marginal ridges mesially or distally, it's an occlusal filling, and suddenly the patient has got periapical lesion. And you have to ask yourself, why does that happen? There must be something else that's going on within that tooth that's caused it to die. So it's usually a crack coronally or a crack vertically that's then extended coronally. And like I said previously, doing surgery, you could usually visualize the crack. So you could see on this tooth here, there's definitely a crack associated with it. Radiographically, again, it's the same thing. You can see a crack associated with a deep pocket all the way extending to the apex. And on a molar, you've got that classical J-shaped lesion around the distal, around the mesial root with some bone loss at bifurcation. It's a heavily filled tooth, it's got a crown on it. So there's a lot going on with that tooth. And usually when you probe around this, you will usually find a deep pocket, which is indicative that this tooth has got a crack. And that's when you might need to think about moving on and replacing this tooth with something else. And you might need to have that conversation with the patient that the sooner you have this tooth removed, the better. The longer you keep it, the more you're going to lose bone. And therefore, if you want to have an implant in that position, you're then committing yourself to grafting and other procedures which may complicate the long-term outcome. Sometimes you can use a CBCT to look for cracks, but CBCTs are unfortunately not sensitive enough yet to pick up a crack due to all the noise that is generated as a result of the CBCT. But you can look for little clues such as a vertical bone defect is where the arrows would form, and localized pockets. And these little things would tell you that this tooth is not looking great. The other part is if you can look at the bite wing, these restorations are very shallow. They're not close to the pulp. So again, these are indicative that, you know, why has this tooth died? This doesn't make any sense. It's not a big filling. This doesn't really add up to what we know classically. You know, big filling, close to the pulp will potentially cause some regression of the pulp horns and then eventual pulp death. But in this case, the restorations are incredibly shallow. And then therefore you have to then, you know, have in the back of your mind that there's something else going on in this tooth, which usually is a crack within the tooth itself. What I use in practice, which I do quite often, is I always look for crack lines within the coronal aspect of or the crown of the tooth itself. So it's just putting the light as close to the surface of the tooth itself, and then you can see cracks forming. So you can see here distally and lingually, there's something that's going on the left picture. In the middle picture, you've got buccal crack. And then when you've done the access cavity, there's another crack that's evident on the floor of the pulp there. And you don't need to buy any fancy equipment to do this. Your light cure is more than sufficient. Just make sure that you've got the guard on it. It's cheap and cheerful, and it's a really good way to look for cracks within a tooth. And by looking at these, you will then, and if you've got a localized deep pocket, the picture then starts to all add up, is that something untoward is going on with this tooth at present. A gum boil is what patients will usually call a periapical abscess, a chronic periapical abscess. And it's caused by you know, long-term infections such as chronic apical periodontitis, and it's become flared up for whatever reason. It's always great to do a GP tracking PA. So use something like a 30 GP, size 30 ISO GP point, or if you use wave 1, you can use wave 1 medium, which is quite a sturdy GP point, or an F3 if you're using pro taper. And usually that will track itself to the tooth that's causing the problem. Sometimes it might go to the lateral aspects of the tooth, and that may be as a result of a missed canal, crack within the tooth. It could be external inflammatory root resorption, or it could be a lateral canal. It doesn't always mean that it's periapically as a result of an infection. It could be other causes for it. And it also is a great way to prevent you misdiagnosing the tooth. Sometimes you can misdiagnose the tooth and treat the wrong tooth as a result of an abscess. So if you're looking at this picture that I'm showing at the moment, you know, it looks like a dead cert that the upper left 2 is the cause of the abscess, but actually it's going towards the upper right 1. So abscesses will always travel through the pockets or the pathways of least resistance, and will come out in the area which has got the thinnest bone. So in this case, it came out from the upper left 2, but actually it's coming from the upper left 1. So it's quite important to do something like this. It's just a great way to know which tooth is causing it. Obviously, the upper left 2 is not looking great either. It's got a periapical lesion, but it just lets you quantify which tooth it's coming from so you can diagnose the cause of the infection. Now, when we're doing a radiographic assessment, I usually take on a very systematic approach. So first off, you always need to justify the PA why you're taking it. Make sure it's always graded. Make sure you audit your PAs at the end of the year, every year, and use the ALARP principles and follow the Ammar protocols. So I break down things into small pieces. I'll report always on the crown first, then I'll report on the periodontium and the roots, and finally I'll report on the periapical aspect. And that means I'm not really missing anything out at any point. From a crown point of view, I'm examining for caries, defective restorations and fillings. I'm looking for any cracks in the crown itself using the light cure. Defective margins of an extracorneal restoration, such as a crown. You can feel around it with a BPE probe. If it feels a catch, then there might potentially be an open margin that's leaking into the tooth itself. And look at the restoration, its proximity to the pulp horn. Has there been any regression to the pulp horn? That may potentially mean that there's been a low-grade insult to the pulp over a long period of time, and eventually the pulp is just given up. So these are little things that you're looking for. Defective crown margins on the top left, or sorry, top right of your screen, that's pulp stones. Again, dens and vaginatus on the lower left. Make sure you always check for those because they can cause silent death of the pulp. And look for sclerosis within the root canal system as well in the pulp chamber. When we're then taking the next step, we're looking at the periodontium and the anatomy. Look for any localized defects, which may be indicative of a crack. Looking for furcur bone loss, which may mean there's a perforation, a crack, or furcur canals that have been infected. And then look for the canals. Are they patent? Are they sclerotic? How many canals can we see? Has there been a previous root canal treatment? Is there any inflammatory root resorption? Is there any instruments that are fractured or any extrusion that's been showing? And periapically, we're looking at a normal PDL. So follow the lamina dura for a normal PDL. If it's widened, why is it widened? Is there trauma? Is there occlusal trauma? So patient's a parafunctionist. Is there periodontal involvement, or is there pathosis? The size of the lesion. So if there's one that you've seen previously, is it the same size? Is it getting bigger? Is it getting smaller? And is there any foreign lesion, bodies such as sealer or GP? Look at the lesion itself. Is it unilocular? Is it multilocular? Could it be cystic? And look at where the roots end up close to vital structures such as your maxillary sinus, the IDN, and mental nerve, because that may mean that the way that you're going to approach your root canal treatment is going to be a little bit different. From a root canal treatment point of view, you're looking for a good coronal seal, caries, good marginal adaptation, any cracks within the crown or within the margins of the tooth itself. Within the root canal system itself, you're looking at three-dimensional obturation. Is there any voids? Have you got missed anatomy in canals? Have you got short obturations? Have you got furcal bone loss and perforation? Is there any localized pocketing? These things you need to look at, because if you're going to redo the root canal treatment, you need to know, why has this failed? There's a reason why this has failed. How can I improve on it? And if we don't diagnose the reasons for failure, it's very difficult then to improve on your revision of root canal treatment. Apically, you're looking at whether or not the GP is within 0 to 2 millimeters of the apex. So you've obturated to that point, whether it's overextended or underextended, meaning there's been apical canal perforation, or the canal has not been well cleaned to the apical third. Size of the lesion, resorption, and the shape of the lesion. If you've got J-shaped lesion, quite a heavily filled tooth, you might have to worry, is there technically a crack in that tooth somewhere? And then you might need to go looking for it. So things I ask my patients when they come in, when they need a re-root canal treatment: when was it done? So was it done over the last 4 years? If it's been done over the last 4 years and the lesion's still there, it's what we call an unfavorable outcome. There's the likelihood of this succeeding or the lesion disappearing is quite slim, as based on the ESC, European Society of Endodontics guidelines. I'll then ask the patient, did you have the rubber dam placed on this tooth when you had the root canal treatment? Could you remember the smell of a swimming pool, i.e. have you had hypochlorite being used in that canal when you've been cleaned? How many visits was it undertaken in? 1 or 2 visits or more? Was there complications during the root canal treatment? Look for the pain history. Sometimes it might not be even caused by the tooth. It could be if a patient says to you, I have pain that is itchy or scratchy, electric shock type pain or burning sensation, that is unlikely to be odontogenic in nature. So that you might have to get that patient referred by another clinician who may be able to diagnose for non-odontogenic types of pain. When was the tooth crowned? And that's quite important. If the tooth was crowned relatively quickly, then you get a better outcome. If it was crowned months afterwards, then the likelihood of failure increases because the tooth might have been affected by the mastication, potentially caused more mechanical failures within the crown. And then ask for parafunction. The pain might be a result of them grinding their teeth and it's very uncomfortable in the morning. Now we're going to recap on diagnosis. Now diagnosis is not always straightforward and easy. It can be a bit of a maze, but we need to know the causes of failure and how can we improve on it if we're going to do it again. The nature of the pain, whether it's odontogenic or non-odontogenic, and it's paramount from a medical legal point of view to have a diagnosis before you do any treatment. Pulpily, if we're looking at the classifications, vital pulp, reversible pulpitis, irreversible pulpitis, and pulp necrosis. So reversible pulpitis, it's localized pulpal microinflammation within the coronal aspect of the pulp chamber. There may be it may be bacterial, thermal, or chemical in cause, commonly associated with a lost filling, defective restoration, or caries. It will be positive sensibility testing, and once you then clean the caries and put new restoration, the symptoms reverse themselves. Irreversible pulpitis up to 60% can be asymptomatic. The patient doesn't even know the tooth has died away. However, when it is symptomatic, you have the classical signs of throbbing pain. It's difficult to localize, especially more posteriorly. Loss of sleep, analgesia may or may not work. Cold seems to help it, hot makes it worse. And be warned that if a patient has positive sensibility testing, but then the pain starts to linger over a longer period of time after the sensibility testing was carried out, that may potentially mean that this is the first signs that the tooth is dying away. Pulp necrosis is asymptomatic. Sometimes there's no periapical infection. Sorry, let me just go back. Got a bit carried away. There will be negativity to vitality testing, and this may occur after trauma or orthodontic treatment, and the tooth has died through what we call sterile necrosis. It wasn't caused by a bacterial death, but the pulp is packed up as a result of the shock of the trauma, causing the blood vessels to be severed at the apex, and that's why the tooth has died away over a period of time. Periapical classifications, so if we run through them, acute periapical periodontitis, so sudden spontaneous pain, marked mobility, it's tender to bite. Patient will usually tell you exactly where it is. And what's happened is there's edema that's formed in the periodontal ligament very, very quickly, but it won't show as a lesion because it just happens so fast and it's incredibly uncomfortable. Chronic periapical periodontitis, most patients won't even know that they've got it. They're unaware, and usually it's an incidental finding radiographically. It may be as a result of decay in the tooth or a tooth that's died away over a long period of time. It may be potentially as a result of root canal treatment that has failed. And it will obviously not respond to sensibility testing, and there will be a radiolucent area radiographically. Chronic periapical abscess, as we've discussed earlier, it will be a sinus abscess. Always take a radiograph with a GP point to diagnose exactly which tooth it's coming from, and an ISO 30 is usually spot on. So how do we justify it? Sensibility testing, so electric pulp test, thermal test, and test cavity. Thermal testing, you have ice, which is unreliable, and the reason why we use thermal testing is because it stimulates the A delta fibers through the hydrodynamic mechanism, and we usually use in practice, or most practitioners will use ethyl chloride, but that's set at -4 degrees. It's quite unreliable when you're using it as a cold test. Things that you need to be investing in is something like Endofrost, which works at -50 degrees, and it's a lot more potent on the tooth. The patient will jump. They will know that that tooth is alive. So try to get some Endofrost. It's just much more sensitive to this type of testing than ethyl chloride. By the time you've sprayed it on the cotton wool pellet, moved it to the patient's mouth, it's quite warm. It's usually nowhere near -4 degrees, and therefore the patient might not feel anything, and we may think the tooth is actually dead, when in fact it's still alive. Heat testing is another way you can do it, either through molten GP points or using something like a Prophy cup at high speed, and the heat will usually cause the tooth to be stimulated and give a sensation of heat. Patients can't feel it. Usually the tooth is dead, but don't overdo this test, because overheating the pulp can in itself cause irreversible pulpitis and pulp death. So this is not a test that we usually use very commonly. Electric pulp testing, some of you guys might have electric pulp tests, and basically it's all based on the ionic shift within the dentine tubules, and they're pretty good for calcified canals in the whole. However, they have a lot of limitations, and it's not something I don't really use electric pulp tests that often in practice. Now, some of the limitations is a false positive reading, so the tooth reacts to sensation, but the nerve itself is actually dead. And that could be because the PDL is being conducted, so the nerves within the PDL are being conducted rather than the tooth itself. You've got necrotic pulp with pus abscess, and that can cause the conduction of the abscess, conduction of the electricity. It might be that you have an adjacent tooth that may be feeling it rather than the tooth itself. You might have a multi-rooted tooth with vital portions and non-vital portions that might feel the electricity, and you're relying on the patient's response. So the patient sometimes doesn't know what they're feeling for. Another problem is the false negative. So the patient feels no stimulus, but actually the tooth is alive. And that could be because of trauma, orthodontic treatment, calcified canals. The patient has taken painkillers before they've come in, so it's calmed things down. The patient may have a high pain threshold, or it's an immature tooth, so a tooth with an open apex, a young tooth, has not formed its nerve plexus. Or you might have a large restoration, like a large composite restoration, which isn't going to conduct electricity. And the pulp has become regressed. So therefore, you might need to then test it a little bit further down on the tooth itself. And that in itself might give you a false negative reading. So when we're doing root canal treatment, we have to justify the root canal treatment. So we need to have multiple, one or a couple of signs to really justify to do it. So either pain, with a periapical lesion, discoloration of the tooth, sinus swelling, or negative sensibility testing. We need to have a couple of these things to really justify the root canal treatment. One on its own might not be enough. So even if you've got sinus swelling, you need to find the tooth that's caused it, and then you'll find a periapical lesion or non-vital tooth. So you need to justify the reasons why you're doing a root canal treatment. Now, finally, we're just going to look at the endodontic prognostic factors. So when we're looking at whether a tooth is going to react well to root canal treatment or not, it really is based on a number of factors. So you're looking at the patient's medical history. Do they have diabetes? Do they take steroids? Because that reduces the immune response, and therefore whatever we do might not work 100%. At the end of the day, what we're trying to do is clean as much as we can within the tooth to bride it of the bugs and then allow the body to heal. But if we have a compromised system, therefore, we might not get the response that we want to clean things up, and therefore it might not work. So we have to look at the patient factors. So look at their medical history. Other things is an extrusion of the root canal filling. So if it's extruded past the apex, some studies will show it won't really affect the outcome too much if the GP in the tooth is sort of sterile before it was obturated. And some say it will, because you've got foreign body reaction. Do we have a perforation? Have you gained patency? If you've got gained patency, you improve the outcome by doubling it. And that's looked at by Endodontology studies. Probing depth, so you don't have a localized deep pocket, because that may mean you might have a perio-endo lesion, an endo-perio lesion, or you might have a crack. If you've got a crack, your outcome is going to be quite poor. Pain, so do you have pain in between appointments? So if you've had a patient who you've opened up the tooth, and then between appointments they've had pain and a sinus and swelling, and it hasn't got any better, that may reduce your outcome. And other things such as a sinus may potentially also reduce your outcome, because you've got a high viral load. So usually I will always tackle these teeth over 2 appointments. Patients will always ask you, well, what's my success rates or my survival rates? Well, success for primary root canal treatment is around 83%. But again, if you've got a periapical lesion, the success rate is less. The reason for that is you have no control over how the body is going to react to it. You have no control over how the body is going to clean things up. Re-RCT has got a lower success rate, 80%, and if it's got a lesion, it can go as far down as 60%, looking at Sjogren studies in work. The survival of root canal treatment is around 95.4 and 95.3% for primary and re-root canal treatment. So if it's done very well, it can last for a long period of time. These are studies survival studies of 4 or 5 years. I think it's about 4 years actually looking at Engetal's work. So again, it gives you a really good parameter that we don't just want to extract these teeth and put an implant. Let's try to save these teeth. They might actually give us a few more years, and that's really important if the patient's quite young. You know, let's try to keep that tooth for as long as possible. Even if it's a little bit compromised, let's keep it for a little bit longer and then delay the implants to a little bit older in life. If the patient's a little bit older, they might want sometimes a more predictable outcome, and then going for an implant, you know, when they're a little bit older is a fair choice, because they, you know, at that point they might not see the complications. The implant may potentially outlive them. So that's how we're trying to look at it, as morbid as that may sound. We're trying to give the patient, their dentition, keep it for as long as possible. If they're quite young and you have an implant in your 30s or 40s, you're more likely going to see the complications of your implant in your 50s and 60s. So you really need to be careful about how we diagnose this and how we treatment plan the patient, but also the long-term cost of implants is much higher to maintain it than an implant. So these are little things that we need to consider when you're diagnosing or treatment planning the case, is that an implant is actually quite expensive over the long run to look after than a root canal treatment. Again, I'd like to thank Kiroku for letting me do the presentation today. It's just a whistle-stop tour of pre-assessment of endodontic cases. I work in London at the moment. I accept cases in multiple places in London, so Northwest London, Hemel Hempstead and Richmond. If you want to ask me any questions, you can find me on Facebook and Instagram, or you can email me at ammar.al-Hourani@nhs.net. And I'm going to hand you over now to Hannah, who will demonstrate the Kiroku software. So thanks so much.
Ammar, thank you so much for that. That was really, really interesting. Can I ask you, you've got quite a few questions that have come in on the Q&A. So
Sure.
If you can access those, I'm sure people really appreciate those being answered.
Yeah, sure. If you want, we can maybe go through a few of them at the very end.
Perfect, whatever is best. So I'm going to share my screen. Let me know if you can see what I can see. Yeah?
Yep.
Perfect. Great. So, very briefly, so I'm Hannah. I'm one of the founders of Kiroku. We started Kiroku several years ago, and it was born out of a long-standing frustration I felt as a dentist. Basically, how much of my time was spent looking at a screen in practice quite often once my clinical day had finished. And that frustration led me to think, you know, there has to be a better way of doing this, and we have to be able to have a technology that we as dentists have got access to, which makes that process a bit easier, quicker, and hopefully can ensure that the quality of our notes is you know, complete. And with Kiroku, we believe that we've created that. So it really is speeding up note taking for our users. So our users are typically spending about 50% less time compared to what they were doing before using Kiroku. And when you think that as a dentist, you spend probably about 1 to 2 hours a day cumulatively doing notes, that becomes quite a significant amount of time per day that you're saving. The system runs in your internet browser. It doesn't require any downloads. It can be an individual decision to use the software, and it works along any softwares, whether that's R4, SOE, Dentally, whatever you're using. For our existing users, I'm going to show you how we can include Ammar's workflow into your clinical practice. And for our new users, I will show you a little bit about how Kiroku works and how it can help you. So I will go straight into that. So as I said, we've worked alongside Ammar to create this template that is capturing all of the information that actually we just listened, you know, what's the important information that we should be capturing. With this workflow, you'll see there's instructions about how to use it. I will show you very briefly, once I've been through this, how you can start customizing this to your needs, and in that we can just delete this section out. Something really important to note with Kiroku is you can type as you would in any other software. So this is not meant to be inflexible, it's meant to help speed things up, but it's also, you've got full customizability. So let's say that we're just filling in some, and we are referred by Mr. Moeller. The thing with Kiroku as well is, dependent on information you input, it will output relevant information for you. We have built this specific to the information that Ammar deems very important that we should capture, but then this can be customized over time. And I will go into that in a moment. So if we record that the patient is coming in pain, it's immediately outputted potential history of presenting complaints there. So if we said that the tooth was previously symptomatic but currently experiencing no problems, and then we can literally click through any parts that are relevant here. So you can select multiple, you can select one, and that's immediately added to the notes. If we run through just very briefly, let's say we have a regular attender, they were in reasonably recently, and let's say that our patient has got a few bad habits. So they're brushing twice daily, but they're using a manual toothbrush, they're using fluoride-free toothpaste, not doing their interdental cleaning, they are doing occasional mouthwash, but straight after brushing. I'm now going to skip ahead to my discussion. And I'm going to show you that dependent on what we selected there, it's outputted the advantages of using fluoride toothpaste, because we recorded that the patient was using fluoride free. We've advised the patient to start doing interdental cleaning, and you can select which one you provide there. Again, as I said, you can type anything that is relevant should you want to. And we've advised the patient to use mouthwash at a separate time to brushing because of the information that was entered. You can see these little symbols, the little dots and the new symbol, and that's to really draw attention to what Kiroku has suggested as a note, because of course you will always have a reason as to why you might not have given that information, in which case you can just delete that out very easily. Again, let's say that we've got a daily smoker. It's then going to ask you how much the patient is smoking a day. And again, let's say that they are not drinking too much alcohol. In this situation, again, you will see that smoking cessation advice has been outputted, but there was no alcohol reduction advice because we've recorded that, in fact, they are drinking below the recommended amount. From that, I'm now just going to just show the topics with which Ammar feels are very important to include in the records. I'm not going to do a full click through of the entire things, just in the interest of time. But you can see how easy it is just to click through the options here, how quick it can be then to take your history. And what's more is, quite often, because this is so easy to see where the information is meant to be input, it can, number one, act as a prompt for you. It can also act as a prompt for your nurse. Nurses seem to be far more confident in helping you with your notes when using Kiroku, because they can see exactly where the information is meant to be entered. They know spelling and they know everything else, so there's not that fear of doing anything wrong. Again, same as before, anything that we click through will collapse down into text, and you can delete lines out if for whatever reason they aren't relevant. Here you can see the information that we should be capturing about the tooth in question. So with restoration present, we have purposefully left that as blank so that you can type in whatever is relevant and be as detailed as needed to be for that tooth. We then want to be recording all of that sort of sensibility testing information that we went over in Ammar's lecture, doing the pocketing, checking whether the tooth is in function, and all of those aspects. And quite a few of those we're going to go into more detail as well. For example, Perio pocket depths around that tooth. So you can go through and record your 6-point pocket chart specific to that tooth and make sure that that is captured. You're then going through your occlusal assessment in the level of detail that is required. Again, we've got radiographic information that can be captured and that report has been left blank again, so you can write that to that level of detail, dividing that out into the different areas. Sorry about the background noise there. And then we can move on to diagnosis. And that will just be able to click through one of those options just to be, if whatever reason one of the buttons is ever not shown there and you want just to be able to freehand type, if you select other, that will collapse down into no text so that you can freehand type whatever is relevant or specific to that tooth. And just to say, of course, there is always going to be the conversations and the things specific to that patient or that clinical situation. And we actively do want those things to be typed in. However, the vast majority of things, when they're that repetitive information, that should be captured with sort of clickable buttons to make things faster for you. In terms of the sort of generation of those clickable buttons, if within this report, for example, if there was a set thing that you are repeatedly adding in there, that can be added as a clickable option in two ways. The first way is that you can edit the template to always output that as an option, and I'm going to show you briefly how to do that. Or if you repeatedly are typing anything in, it's going to detect, Kiroku's technology will detect that pattern, and you might notice sort of the next time you've logged in that you've got a clickable button that wasn't there before. And that is really the exciting part of the technology. This we already discussed, the general discussion, and that's the information that's dependent on other information that you entered. Now we get onto the specific endodontic risks, and you will see quite a chunky area of risk discussion that we need to be going through. Now, this is obviously going to be something that you're going to want to be discussing with your patient. It will also act as a prompt so that you're not forgetting providing any of this relevant information. Kiroku is actually releasing a product within the coming weeks that is going to be able to give you the ability to be able to send this information out straight to the patient, straight after the appointment. And that will obviously be something that you might want to discuss with them, but it's a huge amount of information. So to give them the capability to reference that information afterwards, you can see how useful that would be as well. So I'm just going to pop out of the notes and I'm going to go to one that I completed earlier, and so I can show you how that's then entered into your notes. So a bit of a Blue Peter jobby. This is one that has been clicked through. You can delete this one out. And you can see that that is all largely completed. I've left one button incomplete just to show you. If I press copy here with any buttons left incomplete, this red banner is going to come up for you, and it's going to show you that something has been left unfinished. I don't know about you, but I have definitely, 6 months after I've previously seen a patient, gone back and seen a template left incomplete when I was still using templates. And this is what is going to stop you having that, you know, sinking feeling in your stomach. So if we say that we're going to do a crown, we're going to do an Emax crown after that. Let me exit this. I can now press copy notes. I'm going to drag this in, and I hope that this is clear. Obviously, I don't have SOE on my computer, but for the sake of argument, let's say that this is within your sort of examination tab. You just press Control-V, and that's all of those notes out and completed. So I hope that that communicates how easy it is to insert those notes into your dental software. Very, very briefly, I will show you how you can start making edits to the template. But if you want more information on this, I would recommend, sorry, I'm just going to move this out of the way. I would recommend either viewing we've got a lot of videos that are going to be able to guide you through editing templates to be specific to what you need, or you can book onto a workshop, and that's accessible via the website. You'll be able to see a link to book onto that. So I will very briefly show you how you can start making edits. So if you go into templates, edit, let me just move this out of the way. And I'm going to go into the correct note. So if I go into endo consultation, that little prompt is always going to come out for you. It's just a prompt to make sure nothing is left unsaved. If you know that it's been saved, you can just ignore it. To delete out this section, once you've read that information, you can just press the delete next to the title section, and that will go for you. And just very briefly, I'll show two small things. You know, examining dentist, for example, you're not going to really need a button. That's something where it's always going to be text. So I can just purely just click onto that text and type that in. Nurse is the perfect example. For me, at least, I don't have one nurse always, where I might want to add a few options, in which case I'd want the buttons. So I would hover over those 3 dots and it would just give me the option to output a button. I'd then click on that. Let's say I'll add some options. And then if I preview that, you will see now that that's a clickable option as well. So that's the way that you can start reducing your typing time by inserting buttons like that. And that, broadly speaking, is all I was going to show today. If anyone has got any questions in particular about that, then I'm happy to go through those. Otherwise, I will stop sharing my screen, and then I don't know if you would like to then go through some questions now.
Yeah, sure. Yeah, no problem at all. So first question is, if you use a light cure to detect a crack, would you use the light shield? Absolutely, and you will actually see the crack. It's still quite visible. I wouldn't use a light cure without the shield because you can destroy your retina, so be very, very careful. So yeah, it is possible. If the apices of the teeth are close to the ID nerve or have close relations to the sinus, is it better to refer? If it's close to the ID nerve and you're worried that you may potentially cause a sodium hypochlorite extrusion, or you may put too much sealer, or the GP may poke through the apex, then I've got a couple of suggestions. One, I always prepare these teeth 1 millimeter short of the working length because I don't really want to cause any issues with extrusion. I'd be very careful with the amount of sealer that you're going to put in there as well, so you don't put too much sealer, just you need a tiny bit. And you know, we could do another talk in the future about irrigation, but with irrigation, there's multiple ways that you can do it without causing potential accidents. But I think we'll leave that for another conversation if you don't mind, because it's quite a large topic. There's a question about if the tooth to have RCT is restorable and is a non-working interference, can you crown the tooth and remove the interference? Yes, you can ask the lab to create the crown for you to be light on ICP and out of lateral excursions, or you may want to allow the tooth to be part of canine guidance, so you might want to create canine guidance. Now, I'm quite lucky in the sense I have a prosthodontist in the clinic, so they will have a look at it and deal with it. But as far as I'm concerned, that's how you want to be able to do it, because you don't want to have lateral excursions over a long period of time, because that in its own right will cause failure. How does vertical lesion impact prognosis? Is there a rough figure on success? Now, we know through for perforation, there's 3 prognostic factors that are really important: the time at which you treat it, the size at which it's happened, and time, site, and I've forgotten the last one: time, size, experience, and the material that you use. Now, in this case, with furcation involvement, they're usually, believe it or not, the easier ones to deal with because they're quite evident. If they're quite small, they're easy to deal with. But the only time we would get concerned is if the perforation itself then starts to go down the coronal third of the root. So you've got the perforation on the floor of the cavity as well as going to the root canal system. And that's when we start to worry a little bit, because that's going to be quite difficult to repair. Success rates, if the treatment was carried out optimally for perforations in general, we don't really have any studies for perforations on furcations only. If it was done with classical materials such as GIC and the likes, the success was around 70-ish%. If we used bioceramic materials, it was around 81-82%. There was almost a 10% shift if it was done with bioceramic materials such as MTA, total full putty and sealers, and biodentine. And that study was done by Sue et al. So if you want to look that up, you'll find the results of that study. It's a good study. Abbas, my friend, I will give you a call. Abbas is a friend of mine, so I'll give him a call and answer some of his questions if you don't mind. With the results, so the success rates, they were based on studies by Eng et al. In 2011. Read the studies. They were on 2 to 4 year studies, and they took upon themselves to examine the treatment outcomes of teeth that were treated by postgraduate students at King's, I believe, or Guy's. And the success rate was it King's or Guy's, or was it Eastman? I think maybe it was Eastman. And it was based on 2 to 4 years. And she looked at multiple prognostic factors and survival factors to know whether or not a tooth was going to survive. And if you look at that study, it will tell you what those factors are. Or if you've got dental update, if you type in modern endodontics, James Darcy's got a phenomenal paper on that, where they've basically dichotomized the paper and made it really easy to read. And it will give you everything from how a perforation would reduce the outcome to how over-extrusion would cause a failure of an outcome. Now, if we're going to, there's a question on the extrusion of GP. Extruded GP had a lower outcome than short of the apex. So what we mean by that, when we're doing any obturation, we always want to be within 0 to 2 millimeters of the apex. And if we're within that point, then we're assuming that we have cleaned the teeth very well, we've cleaned the apical third, and that's where you have most of the bacterial ramifications. If the GP has gone through the apex, then we have what we call apical perforation. The working length was not determined well, and that may cause long-term irritation, especially if the root canal system was not cleaned very well and you've got an infected GP point, which may then inoculate the periapical tissue. So if you again look at the paper by James Darcy, he will show that, or that will show, based on Engetal studies, that over extrusion is actually of a worse outcome than under preparation or under obturation. What tips, materials do you use for removing GP for retreatments? So when I do any retreatments, I will usually use like a gooseneck burr, a bit like a rosehead burr, but with a longer shank. And I would usually cut down the GP to the CEJ, so that gives me a really nice floor. I would then use some ultrasonics just to clean the pulp chamber, just so I don't have any debris. And then what I would usually use is something like one curve or reciproc or high flex, the 1 file, the 25 squiggle, and they are phenomenal at removing the GP. Now, what you need to do before you remove the GP is get an estimated working length, check the length of the root, check the length of the GP, and make sure that you only prepare to up to 2 millimeters short of the GP. If you go to the GP point and you go past it, sometimes you can cause a ledge, and that becomes very, very difficult then to maneuver. So always measure your length of the GP, prepare to 2 millimeters short of that, clean it very well, the canal, and then go back in with a size 10K file and try to get past the GP and into the root canal system itself and try to get your working length. And that therefore means that you can get your working length, you know where you're having to prepare to, and then slowly then you can remove that last 1 to 2 millimeters of GP quite easily without too many difficulties. Ultrasonic tips are really good at that point. You can, you know, by using it, you can actually melt away the GP to an extent, but you need to use mechanical files really, or H files, headstrong files, to remove the GP. So for upper molars and canines, lower molars, an H file is phenomenal. For molars, I find it quite difficult, so I would usually use something like a 1-file system to remove the GP point, either rotary or reciprocating, and whatever really works in your hands. I would definitely take out, you know, do some of these, maybe do some root canal treatments on some extracted teeth, and then retreat them just to get a feel of that, because it's not so simple to do that sometimes in the patient's mouth, and it does take a little bit of practice. You can use solvents if you wish, but the problem with solvents is it melts the GP, and therefore it makes it a little bit more of a messy procedure. Also, the melted GP means that it will go into the dentine tubules, and therefore you can't genuinely then refresh that dentine to give you a better outcome and clean the dentine tubule as well. So be careful using sealers. How soon would you recommend a full cuspid restoration to be placed? That's a really good question. I would usually say to the referring GP, if you don't GDP, if you don't mind, to restore it within, you know, anywhere between 6 to 8 weeks, 6 to 8 weeks, as long as there's no symptoms. There is some studies done by Noemi, which he's also released a new study now in the IEJ, which showed that the sooner you restore, was it Al-Noemi? I think, no, it wasn't Al-Noemi. It was another study. I'll try to find it for you guys and maybe get Hannah to email it to some of you guys. But basically looked at the time at which you did the root canal treatment and restored. And if I remember correctly, as long as you restored the tooth within 3 months, you had a much better long-term prognosis. But if you restored it after 3 months or 4 months, then the tooth had a 3 times more likelihood of having an extraction. So the sooner you have the restoration carried out, the better. But obviously that depends on a number of other factors, such as the number of teeth that, the number of sides that the restoration is involving. So is it an MO, is it an MOD, or is it just an occlusal? With an occlusal, you might not need to do a crown. Whether you need to have a crown or a cuspal coverage restoration, such as an onlay. So that's another thing you need to be looking at, because you want to preserve as much tooth as possible. But the rule of thumb is, as long as within 6 to 8 weeks there's no symptoms and the patient's happy, then go ahead and do the crown. The sooner you do it, the better the long-term prognosis for that tooth. Is that okay, Hannah? Is there any more questions?
Perfect. Thank you so much. Sorry, just to answer one question, which is how to add the templates, and that is by hovering over the template. You'll see the option of add stock template, and within there you'll see a whole host of either consultation appointments, treatment appointments, but also our specialists recommended templates as well. Just finally, thank you so much for that talk, and thank you for answering all of those questions. There's a huge number there. And thank you everyone for attending and staying till the very end. And we will be sending out feedback forms after the after today's webinar. Do fill them in, and we'll be sending out CPD certificates after that. But thank you very much. Have a lovely evening, everyone.
Thanks so much. I appreciate your time, and thanks for everyone to take the time to listen to this.
Thank you so much for your time.
Okay. Thanks so much. Bye-bye now.
Bye-bye.